launch, so I'll walk through my talk, hopefully rather quickly. I'm the Chief Science Officer at a company here in Silicon Valley called Neurotrack Technologies. We are a digital health company that's focused on both the assessment and management of cognition and cognitive health. And what I want to talk to you specifically today is kind of how cognition relates to aging populations, which is one of the verticals we have a lot of interest in and that we are designing and working for in the technology and products that we have on the market and are continuing to develop. So this is a nice map. I think this is from 2015. The darker areas represent higher densities of populations age 60 or over. This is 2015. If we fast forward to 2050, we live in a hyper-aging world. This is just a fact. And so this is interesting for a number of reasons, but perhaps most interesting because age is the single greatest risk factor for cognitive decline, pathological cognitive decline, and eventually dementia. So if we look at the world numbers right now, there's about 50 million individuals worldwide that live with a dementia diagnosis. That will be upwards of 130 million come 2050. The same is true for most continents and countries across the globe, particularly the ones that already have higher densities of aging populations. So for example, Japan right now is a country where Alzheimer's disease is already the leading cause of death. And that is a byproduct of the demography of the country. So what does this have to do with kind of the way we look at cognition within the medical system today? Well, in the US, getting information about your cognition through traditional healthcare service providers is a long and winding road. So right now we have something around 50 million adults over the age of 65 that complain of some sort of cognitive issue. For that to be kind of seen through the auspices of the medical system, it usually includes a combination of a primary care provider appointment, and then usually some referral to a specialist like a neurologist or a psychiatrist. And then if there's significant concerns about what's going on cognitively, you will likely see a specialist like myself, a neuropsychologist, who looks specifically at brain-behavior relationships and tries to give a really nice picture of what's going on with an individual cognitively, what might be explaining the changes that are happening, make a differential diagnosis. And then you have what results right now in a major wall, and that is we have no therapeutics to do anything about pathological forms of cognitive decline. Now, at least on the assessment side of the equation, we've been figuring out ways to try and help individuals who have cognitive complaints walk through this process faster. But it's been admittedly quite difficult. Cognition is a difficult thing to measure. It's fickle. It can change based on a number of factors, including who's doing the evaluation, when the evaluation is happening. It's a very different type of measurement than just getting your pulse or your blood pressure. And for those reasons, it's not as simple as to say, well, you can just go do this anywhere. One of the areas where the Veterans Affairs hospitals have actually taken the lead is in using synchronous telemedicine to provide remote assessment of cognition. And for those familiar with synchronous telemedicine models, essentially what this means is you have a provider on one end and a dedicated telemedicine setup with audio, video, and you have a patient on the other side. You usually have a chaperone. In fact, it's necessary to have a chaperone because the way you do these measurements of cognition require a lot of tests that have pieces to them that chaperone or that other healthcare professional needs to kind of provide to facilitate this. So what this amounts to is that while we have a way to do the measurement of cognition remotely, it's actually more labor intensive than a normal face-to-face appointment, which is not really solving the problem we want to solve when we look at the aging of our population and the sheer numbers and the supply-demand mismatch. So, for us at Neurotrack, the question that we've asked is there a way to do high-quality clinically actionable asynchronous telemedicine for the evaluation of cognition? And we think it is possible, but it is challenging because it's not like the ways we typically think of asynchronous telemedicine. When we think of asynchronous telemedicine, we think about things like radiology, we think about things like dermatology. These are kind of store and forward methods that don't require a whole lot of additional support in order to qualify the data you're collecting. Not the case when you're talking about cognitive assessment. There's a lot of quality assurance that needs to go into it. So this is what we're doing. We actually have a platform where we're able to collect multimodal, what we talk about as multimodal neuropsychological phenotyping. This is the idea to collect multiple modes of data at the same time using established neuropsychological paradigms. One of the most important reasons why this is important when it comes to high quality, clinically actionable telemedicine for cognition is it allows a way to reliably qualify the data, right? So this solves what I call the cat on the keyboard problem, right? If you ask for someone to go measure their cognition and bring those results to the doctor, that number is going to show up as a line in a column in some Excel sheet, and you have no idea, right, if your patient was even the right patient who performed that test, or if they got distracted while they were taking the test, or if there was a cat on the keyboard for a portion of that test. And now the data that you're working with is certainly not data that you want to take clinical action on. So the platform that we've developed actually kind of solves some of these really vital and fundamental problems around getting high quality clinically actionable data. It also does something else. It actually creates a multimodal phenotype of an individual's cognitive performance. 95% of cognitive testing is still paper pencil based at this point in time, and it's unimodal, right? It's a single type of data that we're trying to collect, and there's a lot of data that's being left on the table that seasoned clinicians kind of recognize when they're giving these tasks in real time, but they're unstructured, and we're kind of finding ways to structure this data to serve it up to clinicians in a way that's much more helpful. This is just one example of kind of how we have taken commercial grade eye tracking technology and put it into device embedded cameras. So it's important to know that our platform is not using additional hardware. It's using the laptop or the tablet or the smartphone for some of our measures, and using the cameras that are built into those devices as opposed to a hardware-based camera. And it takes a lot of work. That's what we've been doing for a large part of our company's history, is actually doing the necessary engineering work and QA work to show that we can reliably collect eye tracking metrics through a device-embedded camera at the same level, right, the same level of accuracy and precision that you see from traditional commercial-grade eye trackers, which are kind of the gold standard. So that's one side of the house. The other thing, though, which is really important, is that we actually do this because we want to provide individuals with something they can do with this cognitive data. And so our platform is not simply about assessing or measuring your cognition, but it's about managing it over time. We have an end-to-end cognitive health platform where we have individuals step on the platform, do multimodal neuropsychological phenotyping to assess. They can enroll in our memory or cognitive health platform, and then they can actually monitor and measure over time. And importantly, the second piece around engagement with our cognitive health platform is not something we made up. It's actually an existing evidence-based RCT of 2,400 individuals out of Finland. That's called the Finger Protocol, and there's actually now instantiations of this same protocol being performed in about 24 different countries worldwide. Again, because most countries are now realizing they need to do something to start lowering the risk of their aging populations. Some of this might not be surprising, but there are at least between a third or half of cases of all-cause dementia that are strongly related to modifiable risk factors. So these are things like what we would expect: exercise, diet, cognitive engagement, social engagement, sleep. And what the Finger Protocol showed in a very rigorous way is that if you find these at-risk individuals and you engage them in a multi-domain, non-pharmacological intervention, over 2 years, they actually improved their cognition and reduced their risk of Alzheimer's disease and all-cause dementia. Importantly, some of these additional studies in Europe have actually gone on to show that you can see differential rates of conversion in these populations, which is really, really important when we consider that there are no pharmacological options available to us right now. So these are just a couple of examples of the types of things that on the engagement side in our platform, we're kind of helping individuals walk through. But a lot of this is psychoeducation. A lot of it is learning about how there are many, many aspects of our health that are related to our brain health and how they can start into this protocol of non-pharmacological based interventions to start making a difference in their risk. Really quick, interestingly enough, one of the things that the failures of our pharmacological trials have shown us is that the vast majority of individuals with, even with something like an Alzheimer's disease diagnosis, have more than one pathology on board. And this speaks to the heterogeneity of the disease and why we need to take a multi-domain approach to finding ways to reduce risk. I'll stop here just to say, you know, with this kind of data, what we're able to do is then layer on lots of other types of interesting data for us to start phenotyping aging populations in a novel and really innovative way that will hopefully provide value not just for the current individuals who are aging that want to better measure and monitor their cognitive health, but actually start to provide us with a much richer, big data level data set to be able to ask questions of how we can better inform treatments in the future. With that, I'll stop and thank you and enjoy lunch.
Thank you so much. Do you have any questions?
Feel free to find me during lunch.
Okay.
So you were saying that you are helping to reduce risk factors through sleep, exercise, stress reduction, and so forth. Is that all self-reporting, or do you have other levels in this system that actually confirm whether those things are being adequately addressed?
Right, so both and. So the reality is within the app, there's self-reporting mechanisms, but certainly when we do, we're actually part of a 2-year RCT right now being funded by the NIA. And we'll also be collecting other forms of data, whether it's, you know, sleep architecture data from wearables, et cetera, to be able to look at those data in multiple ways.